That sounds like the recording is started. All right, thank you. So I'm David Robertson, work here as a neurologist and do the immunology, multiple sclerosis clinic. Unfortunately, we're back to virtual stuff, so I think these are less fun, but we will deal with it. So we're talking about multiple sclerosis 2021 and real world conversations. So kind of designed this talk for the Commonwealth Neurological Association meeting this year. I'm going to stick to the same format, but there's some of this that was really geared toward general neurologists out in the community, out in the areas where they don't have access to an MS clinic. There's kind of a bulk in the middle of the talk that I'm just going to skip over. I don't have any financial disclosures. If we talk about medications, I may use the trade name versus the generic name, which I think is usually what we use in clinic. We might talk about bone marrow transplant, so if other things come out, there may be some off-label discussion. And then some of the statements, if we do have questions, might reflect my experience and preference in addition to the science, so keep that in mind as well. My agenda is kind of, with all these virtual talks, I feel like an hour talk is just hard to pay attention to and hard to give. But I sort of have this broken down into a few TED Talk ideas. So what we're going to talk about is current thoughts on phenotypes regarding multiple sclerosis. Sort of discuss a therapeutic algorithm or how we think through it, but that's where I'm going to take some of the discussion on actual medications out. And then talk about aging and multiple sclerosis, which is really what comes up a lot in our clinic. I threw in PML in the middle, so that's just going to come up. So it's kind of three TED Talks: multiple sclerosis, phenotypes, therapeutic algorithm, considering PML, and aging and multiple sclerosis. I am always interested in interruption and questions, so find a way to get my attention if you have questions. Okay, some of you who have been around a while have probably seen this slide. I have used this slide for many, many years in teaching. I've also shown it to patients as we talk about treating multiple sclerosis. I feel like any of us that are taking care of multiple sclerosis patients, if you can understand this slide and apply it to how we treat patients, our outcomes are going to be much better. I'll kind of give you a little bit of instruction on what you're looking at. So across the very top, RIS is radiographically isolated syndrome. This would be the disease before it declares itself, either by symptoms or presenting to the hospital. CIS is clinically isolated syndrome. This is when somebody first becomes symptomatic, usually with a focal neurological deficit. And then the evolution is into relapsing or remitting multiple sclerosis. The line to pay attention to is the red line. So that is inflammatory activity or inflammation driven by the immune system, seeing a target within the central nervous system that they think needs cleaned up, and then causing damage to the brain and the spinal cord. To pay attention to that red line that is what our treatments are all geared at. So the animal models, mouse models, are all geared at reducing inflammation. The idea is you reduce the inflammation and therefore reducing the risk of clinical attacks or MRI changes, and then downstream you get a better clinical outcome. As you see, that area is highlighted as a time window for treatment. Inflammation is certainly greatest in the earlier years of multiple sclerosis. So that's when we want to be most assertive, most aggressive with our treatments, is to prevent permanent damage early on in the disease course. The next line to pay attention to as we talk about phenotypes is the green line. The green line is labeled as axonal loss. I would think about this as the progressive part of multiple sclerosis. If the red line or inflammation is the relapsing part or the active part, the green line would represent the progressive part or the degenerative component of multiple sclerosis. Although it seems to build and accumulate over time, this is really where patients experience a lot of accumulated permanent disability. It is thought that percentage-wise, the bulk majority of axonal loss probably occurs early on in the disease course. So I'd say it actually is early on that there's the percentage-wise most axonal loss. and think of that as loss of reserve, which then manifests itself at that 10-year, 15-year, 20, 30-year phenotype in patients where they are markedly disabled later on in the ballgame. So as we talk about phenotypes, it kind of differentiates relapsing disease, progressive disease, but there's definitely an overlap between the two throughout the disease course. I'm going to kind of skip over MRI criteria. So previously, everybody learned there's these fairly delineated types of multiple sclerosis: relapsing remitting, primary progressive, secondary progressive, and progressive relapsing. Those terms still have validity, although the way I think about it, the way I was sort of taught to think about it as I've evolved into this position, is I think of multiple sclerosis with two components, which is, does that person have active inflammation? And the answer is yes or no. Does that person have active degeneration or progressive disease? Yes or no. I didn't really create a slide, but that becomes a quadrant box. You have multiple sclerosis, active, yes or no, progressive, yes or no, and that can label any individual's phenotype of multiple sclerosis. This slide does sort of give us that quadrant box, although it's a little bit different, and gives us a graph to show any individual's multiple sclerosis course can have a combination of inflammatory activity, which is relapse, and progressive activity, which is the degenerative component of multiple sclerosis. And everybody can kind of look at the slide and read. The top left corner is clinically isolated syndrome. So this individual was doing okay, and then it had a demyelinating event, yet after it, they're in a stable time. Their disease course has not showed another relapse, has not showed progressive disease. That person still sits in a clinically isolated syndrome category. If you look at the top right box, that patient is mostly showing active disease, but not progressive disease. So intermittently, there's flares of disease causing new symptoms, but between flares, there does not seem to be accumulating disability, whether cognitive or motor. The bottom left quadrant primarily shows a patient that has active and progressive disease. The active component being the relapses or the new MRI changes, but on some of these timeframes between the relapses, they are accumulating disability. So this person is active and progressive. I would say a lot of our patients are in that category throughout the course of multiple sclerosis. And then the bottom right category is primarily a not active, so no relapses, progressive patient. Now, whoever made this chart threw in a relapse in the middle just to make it tricky. Again, it shows overlap between the active component and the progressive component within most individuals with multiple sclerosis. Any questions or thoughts at this point? And again, not to harp on a slide, but now understanding or seeing how there's different components of multiple sclerosis, and come back to pathophysiology in this slide that shows there is an inflammatory component. That's where our treatments are most effective. The degenerative or axonal component really is hard to change course with our current treatment. Transitioning, here's our current regimen or arsenal of medications. This is not a talk where we're trying to learn medications. I think that's a totally different talk. Kind of around 2012 is when drugs started to hit the market pretty aggressively, and then you can see the years that things are coming out. Every medication on here has a role in the treatment of patients with multiple sclerosis, except Zenbrida, which was withdrawn from the market. Mitoxantrone is just not really used, although the data is quite good. The side effect profile is just too great to be used right now. Again, this is not intended to be a talk about current treatments. So transitioning into a therapeutic algorithm, and again, I'm going to be fairly brief with this part, but just sort of the big ideas on treating multiple sclerosis. There are questions on when to start treatment, what to start, which goes back to the medications, which we're not really talking about in detail, when to switch medications, also which medication to switch to, and then the last question, which will transition into aging and multiple sclerosis, if we can stop medications, and if we can, the question is when we can stop medications. So there are really 2 or potentially 3 therapeutic strategies in multiple sclerosis. One is, once you've diagnosed multiple sclerosis, start a therapy. Don't go with our higher efficacy, higher risk medications at first. See if that patient's multiple sclerosis would respond to a less efficacious but less toxic medication. Start that medication, pay attention on exams, histories, MRIs, and if multiple sclerosis still shows that it is an active disease despite that treatment, you transition to treatment number 2, subsequently treatment number 3 if they fail that medication. That's a valid way to go about treating multiple sclerosis. I'll be critical of that method. If we go back, think about that graph again, the most inflammation is in those early years of disease. Potentially percentage-wise, the most loss of reserve and axonal loss is in those earlier years of disease. So allowing the disease to still remain active is probably not doing every patient the proper treatments to get the best outcome years down the road. Transition that idea to the induction and maintenance therapy, or really an induction treatment, is once diagnosed with multiple sclerosis, hit hard, hit fast, use our higher efficacy therapies as soon as we know it's multiple sclerosis, and either keep them on that medication indefinitely, or the idea would be to later transition to a less efficacious, less toxic medication. There is data to suggest higher efficacy therapies first have a benefit. We just haven't proven it definitively to argue with insurance companies. The third bullet, induction and remission, is really only with one of our medications at this point, called alemtuzumab. It usually is not used first line. In fact, I'm not sure it should be used first line based on toxicities, but this would be more hit hard and then wait to see if the disease still shows itself after alemtuzumab treatment. Personalized strategies based on biomarkers are not currently available. I sure hope this will come at some point. This will be a big task for the scientists. And obviously, if you've spent any time with multiple sclerosis patients or in clinic, really there is autonomy with the patient on choosing what treatment they are okay with. Because we don't have a set algorithm agreed worldwide, nationwide, or by insurance companies, we are really not able to tell patients exactly what they should be on. So patients actually have options on their treatments. We do address risk tolerance with any individual to see what medication patients are accepting to go in their bodies. So these are pretty hard, long conversations. And then, there's lots of parties that help make decisions for medications. I sometimes feel like treating cancer is easier than treating multiple sclerosis because we have set algorithms. You know the tissue, you know the drug that matches that tissue's genetics or tissue markers. So there's a much easier discussion saying we have to be on this medication. Unfortunately, with multiple sclerosis at this point, we don't know which medication matches up perfectly with any individual. Okay, any questions at this point? So just still kind of being efficient and not making it too overwhelming. I'm going to skip through some of these slides. The dogma in multiple sclerosis is once it's diagnosed, start a treatment. And then follow to see if that person has failed treatment. Failing treatment would be a new relapse, a new exam finding, or MRI changes, and kind of the agreed upon number of MRI changes that are not allowed is 2 new MRI changes. If a patient fails those parameters, it's time to consider transitioning medications. And I'm going to fly through these slides because I wanted to make a change. So still kind of making it TED Talk and treatment algorithms. There are some patients where you're concerned that once diagnosed, they're probably at higher risk of significant physical or cognitive disabilities. Therefore, you would argue for a higher efficacy, higher risk medication. So some of the negative prognostic indicators would be the severity of the attack or the relapse, motor or posterior fossa spinal cord relapses are considered a worse prognostic factor than a sensory or even a cognitive relapse. Incomplete recovery from that attack suggests that when their multiple sclerosis is active or highly inflammatory, it leads to considerable disability. MRI activity, and that's also looking at it. What does it look like? Are there significant T1 hypointensities? Again, it suggests that their flavor of multiple sclerosis predisposes to a more severe inflammatory response or loss of tissue. Interestingly, male gender is a poor prognostic indicator. And although we diagnose more younger people, those who are diagnosed older often reach disability levels more quickly than those who are younger. So it's not age dependent on when they become disabled, but as far as how long it takes a 50-year-old man to become significantly disabled is shorter in general than, say, a 25-year-old female. And then non-white ethnicity predisposes to overall worse disease. So in any patient that meets these criteria, either early on or in the middle course of their disease, we'd be thinking of using higher efficacy therapies as soon as possible. There is a reasonable amount of observational data. There's pending more prospective controlled trials. It seems like earlier treatment definitely has a better prognosis. Again, back to that graph that hopefully you remember, with the higher amounts of inflammation early on in the disease course, using our more efficacious medications early, we think reduces their physical and cognitive disabilities down the road. That third bullet is quite valid. So again, if you start with a less toxic but less effective medication early and give it 2, 3, 4 years, some of these medications reduce relapse rates by a third, 25% or a third. That patient's likely to fail at some point, and under the surface, they likely still have ongoing inflammatory activity. So if we as physicians anticipate that they're going to fail in 2 or 3 years anyway, the argument would be to really squash that inflammatory activity as soon as possible. And again, we do think, but haven't yet definitively proven, that starting higher efficacy therapies has better and more consistent outcomes down the road. These are the conversations and arguments we're having with insurance companies on a weekly basis. There is no worldwide agreed upon algorithm. Canada and Europe have some algorithms, but even then you can get outside of the algorithm if that individual needs it. We deal with multiple insurance companies. You're trying to pick a medication that would be approved. It just doesn't always happen. And then hopefully some prospective studies looking at all options will be published to give us more ammo or more data or just more science to guide our treatments. Any questions about treatment algorithm? And you can have questions that are medication specific if interested. We do have some time, or I'll keep moving. So I'm open to interruption and questions. Okay. Kind of a little bit of an aside, although I'm taking care of multiple sclerosis patients, always think of PML as the elephant in the room. So just a quick little talk on PML. So progressive multifocal leukoencephalopathy is the infection, primarily of oligodendrocytes, driven by the John Cunningham virus or the JC virus. So it is important to know what is the incidence of the JC virus in the common population. Ballpark 50%, but it steadily accumulates as people get older. You can see the numbers there, 15% in the second decade, so teenagers, and by the 8th decade, most of us, 80%, carry this virus. This virus is not pathologic unless there is an immune system problem. Our immune systems keep it neutralized or keep it suppressed just by ongoing immunosurveillance. Those of us that are positive but do not have pathology, about a third of people shed virus in their urine. So this virus is an active component of our bodies, but it's just not pathologic. Historically speaking, PML was first described in patients with cancer, lymphomas, leukemias. In the 80s, it really became higher incidence with the AIDS patients, and then it really became associated with Tysabri. So natalizumab, 2004-5-6, was released into the MS population and then had tens of cases of PML very quickly. And since natalizumab is still used, we actually have learned a whole lot about the JC virus because there became more attention. Obviously, there's money to be made by Biogen and natalizumab, so scientists have learned a lot about the JC virus since the mid-2000s. This is not a very good slide. I'll kind of hit the highlights. With treatment of multiple sclerosis, the drugs that are associated with PML, natalizumab is clearly the dominant player. We have hundreds of cases of PML associated with natalizumab. It falls off dramatically. So the MODs, S1P1 inhibitors, so fingolimod is on there. That's Gilenya. We now have 4 of those. It has tens of cases of PML associated with it. The next one down is a fumarate class. This one is Tecfidera. We have under 10 cases of PML associated with fumarates. And then really after that, Ocrevus or ocrelizumab is a B-cell therapy. There are a couple of cases, one for sure associated with it in an older individual. Many of the cases associated with ocrelizumab were patients who were on natalizumab and transitioned to ocrelizumab, and then there were overlap cases of PML. So it is a risk, but definitely natalizumab is the one that we check before starting, continue to observe the patient when they're on therapy, and sometimes discontinue natalizumab based on the presence of the JC virus. I don't prospectively check JC virus in my patients on all other therapies. It's only natalizumab that I'm actively screening for JC virus. Okay, we are at our last transition point. So here's just sort of a case to have you think. I'm sure people can read, or I'll read just so I'm saying something. So a 70-year-old female, a 40-year history of multiple sclerosis, returns for her yearly follow-up appointment. So she was diagnosed at age 30. Her initial symptoms were left ocular blurry vision, bilateral lower extremity sensory change. She did well for many years, yet 20 years ago developed vertigo requiring steroids. She started interferon beta 1b at that time, yet had flu-like symptoms and transitioned to glitiramer. She has continued glitiramer with no new MRI changes. The thoughts, and since we don't do much discussion, the idea should be, does this 70-year-old patient still need to be on glitiramer? And what would be the scientific rationale for having a conversation on continuing or discontinuing medication? So I'm going to reference this slide or this graph that hopefully everybody is starting to appreciate, or first, depending on who you are. As I mentioned, or hopefully back in the beginning, these medications to treat multiple sclerosis are all geared at the inflammatory component of multiple sclerosis. There's a term called immunosenescence, where the immune system kind of wears out, just like our knees, our heart, our kidneys. There's a natural aging process of many of our systems. So the ability of the immune system to mount these significant demyelinating or inflammatory symptoms really comes down profoundly. So this is the graph that would show the rationale for potentially discontinuing medication. As far as natural history studies go, it does seem like over the age of 50 that the risk of active disease becomes significantly less, and in previous studies ballparking about 10%. If you remember, I mentioned progressive disease or the degenerative component of disease. That kind of kicks up in the 40s. With age, back to that slide, there's less active inflammatory changes, and this is based on patients' symptoms, MRIs, and even pathology. And then it's been described, within the last 10 years that in some of our older patients, within lots of patients with multiple sclerosis, but it seems to be in the older population, that there are these plasma cell clusters or B cell accumulating areas in the meninges, questionable lymphoid tissue in some of our older patients. And those findings are associated with more of a progressive component, degenerative component in individuals with those findings on pathology. So I think people probably know that multiple sclerosis is more often diagnosed in the 20s, 30s, 40s, less rarely in the 50s. Over 50 is really 3 to 4% of our new diagnoses. And there is something called very late onset MS, and that's onset of symptoms or showing themselves phenotypically age over 60. Honestly, I used to say you can't diagnose MS age over 60. Well, if you do this long enough, obviously we get the outliers. So I do have a few, I think 4 or 5, that definitely showed themselves over 60. One of those patients she had a brainstem stroke about 6 years prior. That was probably a demyelinating event rather than stroke. But we do see multiple sclerosis show itself age over 60. One reason we don't understand that much about multiple sclerosis and aging and how to handle medications is that the clinical trials, were ideally catching the people with the most active diseases. So it excluded patients over initially age 45, it went up to 50. More recently, some of the newer trials include up to 55, but we don't really have clinical trials in patients that are older than 50 typically. So there is a question, and these are every week conversations in my clinic, of if and when we can stop medication. Age does seem to be an important factor. Previous studies also showed discontinuation in well-controlled patients when they're in their 30s or their 40s. And in those studies, over 50% of patients that stopped their medication showed active disease within months to a couple of years. So I think that shut off the idea that we can treat early and then stop therapy or stop disease-modifying therapy, because there continues to be a significant risk of active disease, even in well-controlled patients in their 30s and 40s. So again, we don't really have prospective trials or certainly randomized clinical trials. There have been some published retrospective reviews in large multiple sclerosis centers. So here's one that kind of set the age at age 60 and looked back on patients who stopped medication for a variety of decisions, and then followed them to see what happened over 1, 3, 5 years. It didn't go that far back. So of those who stopped their medications, it was a combination of factors. A lot of times it seemed to be a personal decision, not wanting to be on medication anymore. Of those who stopped, there was one clinical relapse. And of those patients who stopped that continued their follow-up in the multiple sclerosis clinic and had updated MRIs over that time frame, it seemed to be about 10% of patients showed MRI changes consistent with active multiple sclerosis. It is noted that not all of these patients had ongoing MRIs. Some people stopped therapy, felt well, yet didn't have subsequent MRIs. So I do use this conversation, this piece of data, as I talk to patients about whether or not they could stop medications. And I just sort of reference 10% risk. I think it's somewhat arbitrary, but it gives me some idea of numbers. So in patients who have been well controlled with disease-modifying therapy, I kind of think about 10 years of good control, both clinically and radiographically. We can have the conversation of stopping medication, but there is a risk, I reference about 10%, that you could have a relapse. You could have new MRI changes that could contribute to further disability as you continue to age. It's a hard decision, but then patients get to weigh in on their risk tolerance, their frustration with their medication, or their fear of a relapse and any further disability. Our patients with multiple sclerosis are reaching their older ages with better physical conditions than the previous generation. So we're actually getting more patients in their older years who are still on therapy. It is reasonable to consider patients over 60, 65 who are well controlled to stop medications, but there is risk. I also balance some of that risk with what disease-modifying therapy they are on. Uh, Again, this isn't a talk specifically about medications. There's variable amounts of immunosuppression with our medications. So an older individual on glatiramer, I'm not extremely worried about PML or varicella. An older patient on an S1P1 therapy, I do worry about immunosuppression and atypical infection risk. This is really the last slide. And again, kind of organize it or creating this talk to doctors in the community. This is how I go about diagnosing, starting treatment for patients. Once I know it's multiple sclerosis, I try to get to know them enough to pick 2 medications that I think would be reasonable for their phenotype of multiple sclerosis. Yet also reasonable given their lifestyle, their risk tolerance, if I've been able to judge that. I do write down on pieces of paper what's the good and what's the bad of these medications as we have conversations. And we pick a medication, work on getting insurance approved, and get the person on the medication. We then need to pay attention, updated histories, updated exams, updated MRIs, and if things are going in the wrong direction, we need to again consider a change in therapy. I do consider early high efficacy therapy probably the better way to go about many of our multiple sclerosis patients, and we have those conversations. I really have not brought up stopping medication to our patients pre-60, where I'm actually leaning into it a little bit. Those conversations are starting in the later 50s. I've actually kind of bumped that up to 65 at times, just because I have so many really healthy 60-year-olds, and I don't want to contribute to their disability, so I've kind of bumped it up sometimes to age 65. And that last one is really for the community neurologist of when to know to ask for help, to know what you're comfortable with. If you're in an uncomfortable situation, ask for help. And that's the talk. I'm open to questions. I'm open to everybody going and getting work done. Any criticisms you can shoot by email rather than publicly shame me. All right, so I think we're done. Everybody go enjoy your day, enjoy the fall, and see you later.